Well, thanks for everyone for coming today. Today's speaker is Yi Yin, a lecturer at the University of Bristol. And her talk will be on from signals to function, measuring what matters in human health.
It may take some time.
Yeah, it might take some time to think. Okay. Yeah, and so thanks for coming to the Digital Health Seminar Series, guys. The purpose of the Digital Health Seminar Series is to develop international interdisciplinary connections between academics, healthcare professionals in the industry. It's run by Mikkel over here, Matt, Emily, Sarah, myself, and Karen. And we're usually every 2 weeks from 2 to 3 p.m. On Tuesdays. And just a bit of housekeeping. The webinar will be recorded and be made available online. Online attendees, which is everyone in this case, please stay muted during the presentation. There'll be some extra time for Q&A at the end of the talk, and for online attendees, which in this case is everyone, use the Q&A functionality, the chat, or put your hand up to ask a question. So just a bit of an introduction to our speaker. Our speaker is Yi Yin from the University of Bristol. She's a lecturer in machine learning for health at the University of Bristol. She's an Honorary Research Fellow at the University of Oxford. She holds a PhD in signal and image processing and has more than 10 years of experience in interdisciplinary research at the interface of engineering, AI, and healthcare. Prior to joining Bristol, she held research positions at INRIA, Paris, and the University of Oxford, where she worked on multimodal medical image analysis, computer vision, and AI for healthcare applications. Her research interests spans signal processing, medical imaging, machine learning, and health data science. And her interests are in image analysis, quantitative imaging, healthcare, AI, and interdisciplinary innovation. So yeah. Okay, so Mikkel, so then can you share screen now, Yi, and present? So give us a second to stop sharing and stuff like that.
Yeah, I will share my screen now. Okay. Thank you for the introduction. Can you see my screen now?
Yeah.
Yeah. Okay, I will mute ourselves.
Yeah, I'm going to mute as well. Yeah.
Can I move this?
Yeah, now it's full screen. Perfect.
Are we muted still or no?
Okay.
Yeah.
Yeah. I try to hide the participants window, but it's still there. Can you see this or not?
We don't see the participants window. We can see the set of slides at the moment. Only.
Yeah.
Okay, that's great. First, thank to the organizers. Thank you for your invitation and the introduction. It's my great pleasure to present my research on the LEAP Digital Health Seminar. So today I will talk about signals and functions and how we can measure what matters in human health. There are several examples of the different modalities, like the ECG, EEG, Doppler, ultrasound, CT, or MRI. I mean, you might already familiar with these signals and images. Like ECG is used to monitor the heart electrical activities, and EEG can be used to record electrical activities in the brain. And also there's laser Doppler imaging techniques, which can track the retinal blood flow. And ultrasound, this is the ideal image modality for pregnancy screening. So it can help the doctors to diagnose or predict the adverse pregnancy outcomes. And the last example is the use of CT and MRI for cancer diagnosis. In this example, you can see these CT and MRI, they are performed on the same patient and also the same tumor. We can see the tumor necrosis area, which is the dark region inside the tumor. This happens when the tumor grows rapidly and the cells inside are dead due to the lack of oxygen or nutrition. So this means this data, the images, can help us to understand how the tumor or cancer developed. So after went through all of these examples, we might come to this question. What do these measurements really tell us about tissue function? We have different modality, different data type, different measurements. Do they exactly reveal the real tissue function? This is a question. Next, I will introduce my work on tissue perfusion estimation and try to use that as an example to answer this question. This is a definition of perfusion. Perfusion is the passage of fluid through the circulatory system or lymphatic system to an organ or tissue, usually referring to the delivery of blood to a capillary bed in tissue. The picture on the right illustrates the circulatory system. Well, we can see there heart and the other organs and the two types of blood vessels, artery and veins. And we can also see the capillary bed in the tissue, which facilitate the exchange of oxygen and nutrient in this organ or the tissue. So this system looks complex. So now we move to the question, how can we measure the perfusion? And luckily, so there's the solution. It seems the solution, like by conversion in physiology and perfusion imaging, perfusion is defined as the blood flow per unit tissue mass. So now we have a formula to calculate perfusion. It seems we find a solution, but in reality, can we measure this directly, use the perfusion directly, use this formula? Well, we have different methods and implementations to measure perfusion, but for different aspects. Like there are PET, CT, MRI. We can use them to measure the blood flow per unit tissue mass. So this is the definition of perfusion we just talked about in the previous slide. But however, these modalities, they need the radioactive tracers or the injection of contrast agents. So they are minimal invasive. We can also call them the contrast enhanced imaging. They are non-invasive modalities like power Doppler, laser Doppler, but they do not measure exactly the perfusion as defined in the previous slide. They measure the microvascular flow or vascularity. They are non-invasive and they are very useful too. And there are also other methods like CPP, SPP. They measure the pressure gradient-driven tissue blood flow. They can be used for monitoring. And there are also the other group of methods like CRT, PPI, urine output or lactate. They measure the tissue response to blood supply. They can be used at bedside assessment, but they do not measure the perfusion directly. So we can see there's no single measurement fully characterizes tissue function. There's no ideal modality, no ideal methods. Which methods you can use, that depends on your target organ or your target tissue. In our study, the tissue or the organ is placenta. So I will use that as example. Before the discussion of the placenta perfusion, I will introduce or describe this organ. I'm not sure if you know this organ, but this is the most important one during the pregnancy. The placenta is where the mom and the fetus can exchange oxygen nutrient or waste. And it's so special. It's a unique vascular organ, and it has two circulatory systems, one from the mom, one from the fetus. And it has complex vascular geometries. If you look at the picture on the left, this shows anatomy of the placenta. Okay. We have uterine arteries, they are the largest one. And then we have arcuate arteries, radial arteries, and spiral arteries. And the abnormal vascular development can cause adverse pregnancy outcomes. For example, the fetal growth restriction, which is due to the poor blood flow supply, and preeclampsia is due to the poor spiral artery adaptation. So the placenta perfusion is a very important topic. Now we come to this question: how can we measure the placenta perfusion? Well, it has so complex to circulatory systems and vascular structures, and also for the pregnancy. And for the pregnant women, we need to find a method that is non-invasive and pregnancy safe. For us, we choose the power Doppler ultrasound, which is non-invasive, pregnancy safe, and deep-seated tissue access. Okay. Let's start with the power Doppler ultrasound. If you look at the picture on the left, this shows the basic principles of power Doppler ultrasound. Like there's a transducer which emit signals to the blood vessel, and the signals were reflected by the moving red blood cells. So the reflecting echoes can cause a shift in the frequency. So this is what we call Doppler effects. And the power Doppler measures the strength of the Doppler signal, which is proportional to the amount of moving blood cells and represent the local concentration of red blood cells. So it indicates the blood flow. And power Doppler is less affected by the angle of inclination. This is because it measures the strength or the intensity of Doppler signals, and also is sensitive to multi-directions and low flow velocities. So this seems ideal modality for our study. Okay. Here I showed an example of the power Doppler ultrasound. The doctors scan the patient using the G Voluson ultrasound scanner. And here we can view this power Doppler signals in orange, which is overlaid on the grayscale images. And we can see the distribution and the intensity, which tells us the information of the vascularity. And for our target organ, we need to focus on the intensities within placenta, but not all of these signals. So we need to do these two steps. The first, to identify the target tissue. To achieve this, we need the placenta segmentation. The second step, we need to correct the signal attenuation. Yeah, we talked about the power Doppler signal. And maybe you know that the signal attenuation, once the ultrasound waves passes through the tissue, the signal is reduced due to the absorption or reflection. And for different patients, they have different body composition. And also the placenta is located at different position. So the signal attenuation is different in order to compare the placenta perfusion between different patients, we need to correct this attenuation. Okay. The placenta segmentation. So this helps us to identify the signals within the placenta. There are different ways we can do this. Like there are manual segmentation using the GE Healthcare vocal tool. This method was proposed more than 30 years ago, but it's still widely used in research. Well, one of the reasons is that this is the toolkit developed by GE Healthcare. When customers ordered the ultrasound scanner from GE, they bought this toolkit, so they use it. But this is like very time consuming. If you look at this picture, you need to labor in the contour of the placenta manually, and then they can give you the extraction of the placenta, but it cannot provide more information than the volume. And then to speed up this segmentation procedure, a semi-automated method was proposed more than 10 years ago. In this method, you do not need to labor the contour very accurately. You just join the outside or inside of the placenta roughly. The method can calculate the probability for each pixel belonging to the background or belong to the placenta. So this can help you to segment the placenta in a semi-automated way, but it's still not ideal for us once we are working on thousands of ultrasound images. For our study, we proposed a fully automated segmentation method based on the 3D UNet architecture with transfer learning. We use more than 2,000 first trimester ultrasound scanner to train and evaluate this model, and we can achieve state-of-the-art performance. Okay, now we can move to the next step, the power Doppler signal attenuation compensation. If you look at this picture on the right, so this is an illustration of this signal attenuation I just explained. Or once the signal passed through the tissue, the intensity was reduced. And due to the different locations of this placenta and the different body composition of different patients, we needed to correct this reduction of the signal. So there was a method proposed more than 30 years ago called fractional moving blood volume, FMBV. In this method, they try to find the largest vessel at the same level of attenuation of the region of interest. And this vessel is called 100% vascularity, and it's the local highest power Doppler signal intensity. And they find a standardization value from this reference vessel and normalize the signals in the region of interest using this standardization value. The calculation, it's just like this. It's a very simple one, but it's a very useful one. And this is the only validated method in both 2D and 3D. And nowadays, there's still many researchers are using this method in their study. Okay, in that FMBV calculation, they mentioned a reference vessel. You need to find a standardization point within the reference vessel. This is not direct. Here is an example of blood vessel, and let's see. If you look at the cross-section of this blood vessel, you find a intensity distribution. And then this distribution can of this intensity can be divided into three parts. Like the first one is the region where there wall effects. The second is the 100% vascularity region, and then the third is the area where there are effect of Rouleau. So this is the a group of red blood cells. They stick to each other and cause a very high intensity, but that can cause an artifact. So once we try to find that standardization value, we need to avoid the intensity within the wall effect area or the Rouleau effect area. So we need to find the 100% vascularity point. What they do, they calculate the cumulative signal distribution, and then this is an ideal signal intensity curve calculated from this big vessel from the power Doppler signal. And there's a knee point, or we can call it a standardization point. They use this as the reference to normalize the signals at the same level of signal attenuation for the correction. As we said, this is ideal cumulative curve. And once we apply this to placenta, due to the influence of noise and the way of selection of reference vessel, this cumulative curve is more like a line in many cases, so no knee can be found. So to solve this problem, a more robust method is needed. Okay. Then we proposed a single vessel fractional moving blood volume, which is in short, which is SVFMBV. We refined the cumulative probability curve. We do automated segmentation and localization of the reference vessel. So this can solve the challenge that once the curve is line and we cannot find any point. So this is the scheme or the processing pipeline of SVFMBV. We use the power Doppler ultrasound as input, and then we process the grayscale ultrasound image and the Doppler signal separately. From the grayscale image, we do the placenta segmentation, use deep learning. We find the placenta and also the interface between the uterus and the placenta. This is a landmark for us to calculate the placenta perfusion. And from the Doppler signal, we extract the vasculature, and we find the reference vessel, and we split the vasculature into segments based on the bifurcation points and compare the diameters of these vessel segments to pick the largest one, which can be used as a reference to normalize the signal attenuation at that level. Okay, then so we talked about the vessel sectional and used that as example to explain why the old method proposed 30 years ago cannot meet our requirements. For us, we proposed a new vessel sectional profile model. This depends on these two assumptions. The first assumption is that the Doppler power was proportional to blood flow velocity over a range of power. And in any elliptical cross-section of a vessel, the flow speed or the intensity can be defined by this formula. And here the Imax is the maximum power intensity, and the gamma is the flatness. From this example, at the bottom, we try to extract the surface of the placenta, or we call it the interface between the uterus and the placenta, and we map the power Doppler signals to that interface. So now we can see how it distributed at this interface. If we look at the vessel section, they are elliptical shaped, right? And the intensity of the signal is highest in the center and reduced at the contour of this cross section. That's why we can define this new signal profile model based on this observation. And then we calculate the weighted cumulative probability rather than the signal cumulative probability. So this means we use the power Doppler signal intensity as a weight for each element here. So this can help us to overcome the loss of the knee point problem. So in our cumulative probability curve, we can always find a point as a reference point. And this point is determined by a shear threshold. So this is separating out high shear vessel margins where there are few red blood cells and the red blood cells dense vessel itself. For our case, I mean the uteroplacenta arteries, they are small vessels. The flow profile are typically parabolic, so the parameters can be set as gamma equal to 2 and x is 85. So this is how we improved the vessel sectional profile and define this new weighted cumulative probability in order to analyze the power Doppler signal to find a standardization point in order to normalize the signals to correct the signal attenuation. This is the pipeline for the whole calculation of the SVF and BV. If we summarize it into 4 steps, it's like this. First, we identify target tissue. For us, is the placenta and the interface between the uterus and the placenta, because this area contains the int-villus space, IVS, where the maternal blood from the spiral arteries bathes the fetal villus. So this is a very important anatomy structure. And the next step is the selection of the reference single vessel. We do the automated segmentation of the blood vessels and find a large single vessel located within the area of interest. Then we use this vessel to find a standardization value. This can be found at the high shear vessel margins we just explained in the previous slide. And this value can be used to normalize the signals within the area of interest, because we assume they are at the same level of attenuation. And finally, we calculated the 3D SVF and BV. So we average the power Doppler signal values within the target tissue and divided by the obtained standardization value. We evaluate this method on both the Vasantic data and the real clinical data. Like these Vasantic data, they were generated to be representative of the idealized vessel cross sections and the typical noise in power Doppler ultrasound. There are several examples. as shown in this picture, and to assess the robustness of the algorithm to vessel size and shape, and to extremes of the two most likely noise source in power Doppler ultrasound, the white noise and clutter noise. So we use this seismic data, and we have very stable like standardization value once the big vessel is identified. And here we can see once the diameter of the reference vessel is greater than 2 millimeter, so the calculation is very stable. Next, we evaluate this method and compare it with the FMBV method, which was proposed more than 30 years ago on this patient cohort. We use 145, we use 143 patients because 2 were withdrawn. We calculate SV, FMBV, and FMBV. We compare the distribution of these 2 different measurements. And once we look at the shape of the distribution, it's obvious that the FV, FMBV is more plausible than the FMBV because it's closer to the like normal distribution. And also we compare the log curves of the FV, FMBV, and FMBV for prediction of preeclampsia. Well, it seems that the SV, FMBV works better, but this is just a small patient cohort. To prove this and to do more evaluation, we work on larger data cohort. Like here, we apply this perfusion estimation on the patient cohort that comprised more than 2,000 cases, and we calculated the SV, FMBV at different location of the placenta. We compare the distributions, and we try to identify which is the best one for the prediction of preeclampsia. I mean, now we have even a different patient cohort which has more than 2,000 cases, but we are still working on that. I'm happy to show the results and the evaluation later once we achieve the calculation and the evaluation. Okay. Well, I mean, for this study, I have collaborated with clinicians and industry partners, data scientists. I have a background of engineering. I find this interdisciplinary collaboration is extremely helpful for me to understand what should I measure, and also to understand like the disease, and also what is the most important biomarkers we should extract. Like once we collaborate with clinician, we are from a different research background. The communication is so important. Once I joined this interdisciplinary team, I find it's difficult to understand each other at the very beginning. It seems we are talking about different languages. I can show you several examples. Okay. Once we start the collaboration, we said, now we have expertise from different fields. We are all experts, so yeah, we can understand each other very easily. But it's not that straightforward. When we look at the same picture, like this ultrasound scan, the clinician can see the border of the placenta easily. It seems obvious for them where it is, but for me, I cannot see where is the border of the placenta. So they said, oh, it's just there, and then I will ask, where is the border exactly? So I know the clinician or the sonographers, they have been trained for a long time, or they are real expert in that field, so they can identify the visual observation. They can see more than I can see. But after this discussion, like they help us to identify the control of the placenta manually as an input, and train us to understand the organ and also the structure of the ultrasound. We developed this deep learning algorithm to segment the placenta. So this method works very well. And sometimes it works better than me. For me, I worked on this subject for several years, but I can still be doubted about the border of the placenta, but the deep learning method can do a very good prediction, like this one. Okay, so there is another example. So it's like the discussion about the qualitative and the quantitative estimation. Once we work on this Doppler signal, we try to find the largest vessel as a reference for the normalization purpose. So then the clinician said, okay, let's select the vessel that is big enough. So my question is, like, how big is big? And there are so many vessel segments. We can calculate the diameter or the length or the volume. So how can we define which one is big enough? Using the image processing, the segmentation, we extract the vasculature from these Doppler ultrasound images, and then combine the anatomy information from the placenta. We can identify the vessel within the region of interest, and that is big enough, based on the understanding from both the clinician and the engineers. Okay, so that's why I would say the communications is so important in the interdisciplinary collaboration. Once we talk about the same thing, but in different way, I feel like, well, each of us should be more patient and to learn from each other and understand each other. Okay, and next, I will talk about the collaboration with industry. Well, the commercialization of a method is exciting. Yeah, we all hope our work can be useful in reality, in clinics. And this collaboration is always a very long journey. Like there are administration issues. You need to file a patent or licensing your software. And sometimes there's a conflict of interest. And for people who are working in academia, this also means a big delay in the publication of your work. You do a lot of work, but you cannot publish them timely. Sometimes there's delay of years of work. Then your work might lose the opportunity to be published after this long time of delay. Okay, for this study, we start this collaboration with Perspectives, which is an Oxford spin-out company, in May 2022, like 6 years ago. we work together to commercialize this method. We obtained 2 NIHR AI in Health and Care Awards and a Sir John Soane Charitable Translational Biomedical Research Award. For both for these grants, I'm the co-I, and it's my I feel it's my pleasure to have the opportunity to work on this collaboration with the perspective, with the clinician, and to make the method finally useful. And then in February this year, there's a spin out launched based on this placenta perfusion estimation study. The name of this spin out is Oxalate. This is the AI-based ultrasound technique for tissue perfusion analysis. I started to work on this project since 2018, and then we have this very exciting new funding or new methodology. We started collaboration with the industry in 2020, and then there's a long time of hard work on this evaluation of this method in clinical setting, in using the NHS accessible data, and also use this different patient cohorts with the data collected from different hospitals, which are like international collaboration. And then, well, finally we have a startup company. Yeah, I feel very glad to be part of the team and contribute to this commercialization and development of the method. Okay. So next, I will talk about the data and the techniques, because these are also the challenges when I work in this interdisciplinary collaboration. I always encountered like data. There should be a very careful quality control in data collection. Yeah, if you are working on real patient data, you can understand me that the data collected, and they are always like I cannot say it's bad, but it's not ideal. They are missing data. The quality is terrible, or you need to do a lot of pre-processing before you can really apply your method. And also now we are talking about data-centric AI. So it means the data collection, sometimes it might be more important than the AI model that you are developing. Because my collaborator from the hospital always said that the rubbish in, rubbish out. So we spent quite a lot of time on the data control and data pre-processing. So I find this is the important challenge, but most people they are not talking about as much as the technologies. Like we are always talk about, we have new AI models, we have new techniques, but data itself is also very important. Okay, then the techniques. Now we are using like big data, AI, some multimodal, large language model. But once you are developing a method, it might be not that new or very complex, but it's very stable. So that is good for commercialization. when we talk about our methodology or techniques with the industry partners, so they are looking for a method that is stable, robust, and can be used in reality, not the newest algorithm. So we can see that in this interdisciplinary collaboration, we are trying to find a technique and to make a balance between the model complexity and the performance. And also the implementation of new algorithm. This is also challenging. I mean, for this like these projects or research works on healthcare field, this is always like a long time preparation, start from the data access, like ethical issues, then data collection, data quality control, and then usually there are also people they are working on the methodology or develop the method in parallel, and then we have a very good performance method. After this hard work, several years hard work, but then now we find their new algorithm. Should we move from the old one to the new one? But this is also very difficult to make a decision, because once you are using a new algorithm, maybe you need to modify your existing processing pipeline, which works pretty well in your data. So that's what I understanding for applying the new techniques in this like interdisciplinary collaboration or commercialized projects or the methodology. We are not always find the new thing or to like to chase for the complexity model. We are trying to find a robust and reliable method. Okay, now we move to the last slide, the take-home messages. Signals and images provide observation, but may not reveal the underlying mechanics. Well, as we discussed at the very beginning of this talk, and this quantification is valuable only if we identify measurements that truly reflect function, such as the example of SVF and BV. AI can help us to infer function rather than merely describe appearance. And finally, the interdisciplinary collaboration helps us identify measurements that matter in clinical practice. Okay. Thank you for your attention.
Yeah.
Thanks for the great talk, Yi. Now, do we have some time for questions? If anyone has questions, please put it in the chat or raise your hand.
I can start.
Yeah, sure.
People, I have a couple of things. One, you mentioned the Sapphire wheel test in one of the slides in order to test for normality, but the data that you were showing had finite support, I think. Is that appropriate? Or maybe I misunderstood something there.
Which part?
You showed two distributions, one that looked normal and one that looked like parabolic.
Oh, this one, yeah.
But then you mentioned the test that was run, but I was thinking it may not be actually. No, it's not this one. Well, yeah, this one here. Is it that the values are between two ranges or not here?
This there are 5 different perfusion measurements. So this depends on the region of interest. Like if you look at this table at the bottom, there are location information. SVF and BV1 is the volume of the tissue between the uterus and 1 millimeter thickness from the uterus into placenta.
Yeah. Then it means
if you look at here,
it cannot be less than 0.
Yeah. Oh, sorry.
Yeah.
And then the second one is 5 millimeter thickness from the interface between the uterus and the placenta into the placenta. So this means the different location of this area inside this placenta. So you have different calculation. If you look at the anatomy of the vasculature within placenta, you can see at different distance from this uterus interface, you have different types of arteries. So the concentration of this, like the blood, red blood cells are different because there are different types of vessels, and the blood flow are also different at different position.
Yeah. Okay. Any other questions? I have a question about the starting a spin-out and your role as a lecturer at the University of Bristol. How do you find that? Do you find that easy, difficult, or?
I find it's I thought it's clear possibly for me, but then once I lead a pilot study, I find it's very challenging and difficult even for the first step, the data access. Yeah, we have a good idea, we even have a proposal, we know what we plan to do, but we need the data. So we convince the collaborators to collect data for us. But maybe you understand that we need to to get this ethical approval
Yes.
and access the data and sometimes they do not allow us to use the HPC. How can we process the data using deep learning without HPC access? So there are always challenges before we can really to explore or to develop new methods. I said it's a long journey to do that.
Yeah. Any other questions?
I have one small question. In one of your earlier slides, you were talking about how you implemented a technique for segmenting, I think, the placenta.
Yeah.
And you said you use a UNet. And you was using transfer learning. Can you go in a bit more into detail about that? Like, what was the pre-trained data and how much samples did you use for fine-tuning?
Okay. I mean this.
Yeah, I think so. Yeah.
Yeah, I see. I mean this transfer learning. The model is the model we used is trained on our own data. We developed this 3D UNet architecture in 2018. That's a single class segmentation. We only segment the placenta, and using this more than 2,000 images for the training and evaluation test purpose. We split this into 3 sets, and then we move to the next stage. We try to do the multi-class segmentation. Yeah, as shown in this picture, you can segment the placenta and also the fetus. And to do this, we compared the structure. We find that placenta is the most difficult organ. Yeah, as we show in another picture, it's very difficult to tell where is the border of the placenta. But for the fetus, it seems much easier to find the contour. And also this area within the blue contour is the amniotic fluid, which is completely dark. So once we work on this multi-class segmentation, we thought we do not need to work on this whole data set of this more than 2,000 images. So we used 3,000. It's like a subset from this data sets to do the manual segmentation, the manual labeling of the different components, placenta and fetus and amniotic fluid. And based on the model, the single class model, we have trained on the whole data sets. We didn't use like a fundamental model trained by the others. We use our own.
Yeah.
I can follow up with, from there. So you use the 3D UNet for this situation with ultrasound images. Well, could something similar be used on like whole slide images, for example, to segment parts of a whole slide image?
Yeah, whole slide image is it's a different modality, and also the whole slide is 2D image, so we cannot use this model directly on that one. Yeah, I think there already existing UNet architecture for 2D segmentation, and also there's a more advanced models now we can use for the 2D like segmentation from whole slide image and the pathology slide.
Any questions online, or doesn't seem to be any questions in the chat type thing or Q&A? Then any question from you, Mikael?
No, I'm fine.
Then just want to say let's thank you for a great talk, and I think we should leave it there.
Yeah.
Any other comments or anything?
No, thank you for joining.
And thanks everyone else.
Yeah.
Thanks you for joining, and everyone else, thank you for attending. And hopefully we'll let you know when the next seminar series is soon.
Yeah, probably in September.
Yeah. Okay. Well then.
Thank you.
Thank you everyone.